Good afternoon, everyone. A very good afternoon once again. Welcome to MGM Healthcare's Facebook Live Kids Health Talk, a series of talks from MGM Children, the Department of Pediatrics and Neonatology at MGM Healthcare, Chennai. We try to bring to you once a week talks from pediatricians, pediatric super specialists, and associated specialists on talks which we think that parents and families may find useful on topics related to children and their health. Today we have with us Dr. Radhika Ramesh, a, a fetal medicine senior consultant. Now, what is this fetal medicine? She is a specialist in doing ultrasounds on pregnant mothers and looking at their babies. So, when mothers are pregnant, the baby is called a fetus, and this specialty is called fetal medicine. We trust you have found our talks useful so far. We thank you for your support. This helps us to bring you more talks on more useful topics. You'll continue to find these on Facebook and YouTube whenever you want to access them. If you have any questions during this talk, please feel free to enter into the chat box and we will be happy to get back to you. Dr. Radhika is giving, this is her second in a series of talks. In the first talk, she talked to us all about scans in pregnancy, an overview of scans in pregnancy. How many scans does a mother need during pregnancy? What does a mother need to expect during these scans? In this talk, she's going to talk to us specifically about the Anomaly Scan. Many of you would have heard about this, the 20-week scan or the Anomaly Scan. So Dr. Radhika is here to talk to us all about the details of the Anomaly Scan. What does a fetal medicine specialist look at in an Anomaly Scan? How does a family take it from there if there is anything abnormal in the Anomaly Scan? What all do we take a look at, how it helps us in the pregnancy, and this forms a very important part of care of pregnant women. Over to Dr. Radhika. Welcome, Dr. Radhika.
Thank you, Nisha. A very good afternoon. So last session, we went through an overview of what all scans we do in pregnancy. So now we'll focus on a 20-week scan. So what is that magic number 20? Actually, it's not exactly a 20-week scan. So it is in the mid-trimester. In the pregnancy, we divide into 3 trimesters, like first, second, and third. And the second trimester, mid-trimester, would be the anomaly scan. So when a family comes or a pregnant mother, she comes to the scan room and I tell her I'm going to do an anomaly scan for her. Immediately she's terrified. What is this? Why an anomaly scan? So it kind of creates a very negative feeling in the mother. So that is the doctor is trying to find out something abnormal with my baby. It is not so. 98% of pregnancies are normal, and 98% of the pregnant women, they deliver a healthy, normal child. About 1 to 2% of them do have problems. So to find out that 1 to 2%, we need to scan all the pregnant women with the same attention. So we find out the 1 to 2% of the problem women. So why that magic number 20? It's not exactly 20. It's somewhere between 18 to 22 weeks. The reason is the baby is kind of almost fully developed, or the organs are well developed. It's easier to see because baby weighs around 400 to 500 grams at that time, and it moves around freely. There is good amniotic fluid. The mother is comfortable to lie down. So all these factors kind of make us easy. For us, make this easier to see the baby, so we can see the organs in detail and make sure everything is fine. And also there's other reason for the 20-week number. Why not 24? Why not 28? Because the baby is bigger at 28 and it's easier to see the heart, easier to see the bowel, easier to see the kidneys. But the government, according to the health ministry, whenever we find out a major structural defect in the baby, which may or may not be compatible with life, when we want to end the pregnancy, the rule says that we cannot do terminations after 20 weeks. So that according to that guideline, as well as the ease in examining the fetus, we have this golden number 20. So anywhere between 18 to 22 weeks will be the anomaly scan. So most of us prefer to call it as a target scan. That's a TIFA scan rather than calling it an anomaly scan. And It's mostly for reassurance. As I told you, 98% of the women have normal babies. Only 1 to 2% will have babies with problems. And we have to really scan with in great detail all the 100% of the women to find out the 1 to 2% for scans. So that's why we prefer the 18 to 22 weeks scan, which is otherwise called the mid-trimester scan, otherwise called a target scan, which also is called TIFA, that is targeted scan for fetal anomalies. So mainly we look at the physical appearance of the baby during this scan.
Thank you, Dr. Adhika. That really gives us a clear picture about what the scan is all about and why we do this at this particular time. So, going to the next question, what are the common anomalies we see when doing a 20-week scan? Can you give us an overview?
Yes, the common anomalies would be fetal
Neural
cranial
tube.
in CNS anomalies, that is central nervous system anomalies, which otherwise we call as open neural tube defects. The most common one would be anencephaly. That is when the skull of the baby is not developed. That is diagnosed mostly 100% in anomaly scan or even earlier. The other common central nervous system defect would be the spina bifida, that is open spina bifida. So there is a defect in the spine vertebrae, and also there is a protrusion of the nerve fibers from the spinal cord. There is a skin defect in the baby. So what happens is the nerve fibers kind of get exposed to the amniotic fluid and they get damaged. So the baby's spinal cord actually gets damaged, and the baby's functions of the limbs and the body becomes disabled. So that's a very serious defect, causing a significant morbidity to the baby. It's not a life threatening anomaly, but still the baby will suffer a long term neurological problem. So this is the most common anomaly which we find out during the mid trimester anomaly scan. The second would be a facial anomaly. So most of the pregnant women are concerned that I want to see the baby's face. Is the baby's face okay? In my family, somebody had a problem with the upper lip. So the most important cosmetic as well as having a very significant impact on the baby's life would be a cleft lip and palate. That the baby's face we can see very well in an anomaly scan. So that is common anomaly which we can diagnose during the 20-week scan. The third would be abdominal wall. So as we all know, the umbilical cord is attached, one part of the umbilical cord is attached to the baby's abdomen, the other in the placental side. So during that attachment and development, there are certain things which can go wrong during the process. So the bowel can protrude into the cord that is outside. The bowel may not stay inside the baby's abdomen, causing abdominal wall defects. That is, the bowel which should stay inside the baby's abdomen is actually outside, causing bowel damage. This anomaly may not occur alone. This can occur along with many other abnormalities, and that will cause a significant problem to the baby. The baby will have to undergo a major surgery after birth, and after surgery also, the baby will have to undergo many problems before it goes to a full recovery. And sometimes even the liver can get out of the abdominal wall through the cord, and those babies will have a hard time in the surgery and they may not survive also. The other common abnormality would be cardiac defects. So the cardiac defects are very common than we think it is. And we do not go by any particular reason to look at the heart of the baby in detail. Like we look at the face, we look at the limbs, we look at the spine, we also look at the baby's heart in detail. So we pick up the major cardiac abnormalities in a 20-week scan. Among the abnormalities, next to the open neural defects I told you, cardiac anomalies also contribute to a very significant number of birth defects. Then the next common defect would be the urinary tract abnormalities. They are very common. The the renal abnormalities range from very mild to severe ones. The very mild ones are usually not of much concern because most of them kind of resolve before birth, or they do not cause significant morbidity after birth. Some abnormalities like blockage of urine, that is the kidneys accumulating urine, not letting it drain, those kind of abnormalities can be treated after birth. But sometimes what happens is, if the one kidney is damaged and the other kidney is fine, those babies are perfectly compatible with life, and they can be managed very well postnatally. Sometimes what happens is both the kidneys do not develop well, and both the kidneys are showing signs of obstruction. Then those babies are definitely not compatible with life, and this is a main component of our anomaly scan, is to document both the fetal kidneys are structurally normal. So then comes the limbs. Mainly when you look at a cardiac anomaly, nobody is going to know once till the baby is born, and the baby is going to look normal at birth, whereas face and limbs are the one which has cosmetic attention also, because when the baby is born, first thing they look at the face, they look at the limbs, and majority of the parents are concerned if the baby's face is okay, limbs are okay, all four limbs are there. The common major limb malformations like the upturning of the foot, or the presence of one limb, or limb reduction defects, all can be diagnosed in a 5th month anomaly scan, because that's a crucial time, because once a baby grows, it occupies the space in the uterus and not much space to move, whereas in a 20-week scan there's good liker, it'll keep moving keep moving the four limbs. So we'll be able to trace out that all four limbs are developed well, and the common limb anomalies we can diagnose. So these are the common malformations which we see during the 20-week anomaly scan.
Thank you very much, Dr. Radhika. That gives us a really good overview of what are the anomalies that you look at and what we can find. So, asking you the next question, which will probably be the top of any parent's mind: does the finding of anomaly, mean termination or ending the pregnancy?
Um, Finding an anomaly does not always mean termination, because as I told you, the common anomalies, most of the babies can live, except for conditions like where the baby's skull is not developed, or both the kidneys are not functioning. The conditions like these are not compatible with life. The baby will die soon after birth. So in those situations, termination would be an option. Whereas even in conditions like the spina bifida, or a large cleft lip or palate, or cardiac defects, most of these babies can live with treatment. That is, they will require some major surgery or treatment after birth, but they can live for a long time. But we have to look at, living is not only the option we are looking at. The quality of life for the baby, the how the baby is going to cope up, how it's going to suffer, how the family is going to get affected, we need to take all this into consideration before thinking of what to do with the pregnancy. So as soon as I tell a pregnant woman that the baby has got an anomaly, it means I've found out a problem. That directly does not mean termination. I've come across many situations that after finishing a scan, I tell the pregnant woman, oh, I see a problem here, and I want to look at you more. I want to do some further testing. I want to refer to a specialist. Then immediately what happens is she goes in for a termination immediately. So she should not jump into such decisions. So an anomaly does not mean termination. An anomaly is finding out a problem. Then we need to kind of group the problem, find a cause of the problem, and whether it can be sorted out or not.
Yes. So thank you, Dr. Radhika. We will take us down this further path of what we do down this once anomaly is found out. So, for our next question, is there any other testing that any further testing apart from scanning?
Yes, 90% of the diagnosis is by scanning only. So we actually examine the fetus by ultrasound, like somebody is examining a newborn. The further testing would be, once we find out a problem, we want to know whether the baby's chromosomes are normal. So because most of the anomalies, we do not know what is the etiology actually, and it can be sporadic, that is just like that it happened, or environmental influence, or multifactorial, or we don't know the cause, many causes put in together. So actually we cannot point out why an anomaly happened, because that will be the common question a couple is going to ask me, like why it happened, why me, what I could have done or what I could not have done this to happen. So there's not much they can do about preventing the problem, or making having a baby with an anomaly. So the one test which is available is, we can study the baby's chromosomes. That is, the actually most of the anomalies can have a chromosomal cause. A chromosome is what we find in the blood. All of us have 23 pairs of chromosomes. So if there is any extra chromosome in the blood of the fetus, or if there is less or more chromosome, then the development of the baby becomes a problem. So what we can do is, we can test for the baby's chromosomes. How we do it is, most of the baby cells are present in the amniotic fluid surrounding the baby. So we do under ultrasound guidance, that is, we look at the fluid, the baby, and we look at a baby free or a cord free pocket. We take some fluid and send it for chromosome testing, which could be a karyotype or a microarray. So these tests will look at the baby's chromosomes, and it might tell you why the problem happened. If it is a chromosomal problem and the baby has got a physical defect, then it is more serious problem. The baby is not likely to have, suppose the baby has a cleft lip and palate, I can counsel the couple saying that the cleft lip and palate can be operated by a multidisciplinary team and the baby can do well. But if the cleft lip and palate baby also has a chromosomal abnormality, means the overall development of the baby is going to be a problem. So in that case, the couple might opt not to continue with the pregnancy. So to find out why it happened, and to make decisions regarding continuing the pregnancy or ending the pregnancy, further testing like karyotyping or microarray will help.
That's very clear. Thank you, Dr. Radhika. So further down, the next step. Now we found that there is an anomaly. We've done karyotyping that will help us with our decision making. And so, could you give us an overview of how you approach an anomaly in the pathway?
First, we have to give the option of anomaly scan to the pregnant woman. So first we have to explain. So as I was talking about the pathway after an anomaly, which goes through a multidisciplinary team. So once the anomaly is diagnosed, the next the parent want to know what type of anomaly, whether it can be treated, and who should treat the anomaly, when it can be treated, just the baby is in utero or after birth, and who will treat the baby. So like in adults, everybody goes to a specialist for different problems, like headache, a neurologist, or a bowel problem, a gastroenterologist, or a limb problem, an orthopedician. The same way, baby is a mini human. So we'll have to look at the baby like that. And a fetal medicine specialist role is to coordinate everything and make an overall decision for the mother. So for example, when the baby has a cleft lip and palate, what a fetal medicine specialist can do is, we can see whether how severe it is, how big is it, whether it's one side or both the sides, the rest of the face is okay. Are there any associated problems? Unfortunately, most of these anomalies do not come alone. They come with a set of other problems also, other system problems also. So my job will be to make sure that cleft lip and palate is the only problem with the baby. And also, as I mentioned earlier, I can also do a chromosome test. So if the chromosome test karyotyping is normal, and the rest of the baby is normal, and the cleft lip and palate is the only problem with the baby, then what I can do is, I can refer the mother to a craniofacial or plastic surgeon. They have a big team. So they will explain to the mother how to handle the baby after birth, where the baby has to be delivered, when the baby has to be operated, one surgery or two surgeries, how the baby will do after birth. So it is not only a problem limited to the fetal medicine or the obstetrician, so it extends to the other specialties where they also have to get involved with the management. Or in certain situations where suppose as I told you, spina bifida is a common anomaly. So it is not actually, it is the babies with spina bifida can live, it's not incompatible with life, but the baby will need surgery after birth. So a neurologist or a neurosurgeon will assess the baby and see how big is the defect, what is the extent of damage. They will do further testing like MRI, and they will operate on the baby, and after operating, what will be the quality of life for the baby. So that can be discussed with the other specialties also, and make sure the baby has the only problem and the chromosomally baby is all right. Then they will decide whether to continue the pregnancy or terminate the pregnancy. So the fetal medicine specialist role here is primarily first to make a diagnosis and make sure that's the only problem and not a multiple problem, and no associated problems like chromosomal problems, because that is going to change the game entirely. Even if it's a single anomaly, if there is a chromosome problem, the baby may not do well after birth. So after getting all this information, refer to an appropriate pediatric specialist who will guide the parents of what to do next. So most of the time the question we ask, the parents ask is, what is the treatment? Whether the treatment can be done when the baby is still in the womb, or we can treat after birth. So it is mostly after birth only. So many times you see a lot of information in the internet or people talking, so the treatment can be done while the baby is in the womb. Let me tell you, it is not for all the problems. A very few conditions, and with lot of guidelines, we can treat some problems in utero. So this is what
next step
happens. So we can group the anomalies. The whole discussion is, we can, once we find an anomaly, we can group the anomalies which are not compatible with life. I can give you examples, like the baby's skull is not formed and both the kidneys are not developed, or both the kidneys are blocked. So these kind of problems are absolutely not compatible with life. So the mother can opt for a termination. Some anomalies which are treatable, they can be operated, but we have to know what will be the quality of the life for the child later. So those anomalies would be like a common spina bifida, a large cleft lip and palate, or a cardiac anomaly with a significant or a serious or complex cardiac abnormalities. These babies can be operated, they can live, but the quality of their life will be very poor. There are some anomalies where are correctable, which will not alter the quality of life, would be like a small cleft lip or a talipes deformity. These deformities are correctable, and the baby will have an absolutely normal life after surgery also. There are certain things like ear tag or an extra digit. These anomalies purely for cosmetic correction. So we can actually broadly classify anomalies which can babies cannot live at all, anomalies which have problem but can be managed and the babies will do well. Anomalies can be managed, but the baby after surgery also, post birth surgery also may not do well, or some few cosmetic problems which can be sorted out later. So you cannot say congenital anomaly means termination. So this is how we group the anomalies and proceed to the next step.
Thank you, Dr. Radhika. So you have really clearly put us into the picture of how, when you look at an anomaly, a fetal medicine specialist is really looking at what is the way forward, where will this, how will the baby cope with this, and what will be the associated conditions. And it will be a way forward working with multiple specialties, as I understand, as you said.
Yes, exactly. When we are working with the multidisciplinary team, the information they get also is good. So the authentic information of how the baby is going to do after birth. So one question which I really want to discuss in detail, because that will be the question which many parents ask me every day. So can we treat the anomalies before the baby is born, or only everything is after birth? Unfortunately, the answer is most of the anomalies, the definitive treatment is only after birth. In the in utero period, what we do is sometimes we do in utero treatment just to buy time. That is, the baby has to grow enough to prevent organ damage. So, when I diagnose anomaly is 28 weeks or something, I cannot deliver the baby at that time and operate because the baby is premature. So, I want to wait till 34 weeks. So, in utero, the organ damage is going to be more and more. So, when I deliver the baby at 32 weeks, I may not be able to do anything for the baby. So, for that purpose, we do some procedures which will prevent further damage to the baby, and we can wait till the baby is grown and to be delivered. Such common procedures would be done only in such uncommon procedures will be done only in specialized centers, in very few centers all over the country. The common problem would be the fetal urinary tract obstruction. So, when there is a problem with the baby's urinary tract and the baby is not able to pass urine, what happens is the bladder distends and there is reflux of urine into the kidneys, and there is no fetal urine surrounding the baby, so no amniotic fluid, so the lungs get damaged. So, but this condition can be treatable. The obstruction can be relieved by a pediatric surgeon. For that, the baby has to be born. So, when we diagnose this problem at 28 weeks, I cannot deliver the baby and give it to the pediatric surgeon to operate because the baby is very preterm and it may not tolerate a surgery. So, in that case, what we can do is we can do a temporary procedure. We can put a shunt in the baby's bladder, let out the baby's urine into the amniotic fluid. So, the progressive damage to the kidneys are less and more fluid, which means the baby's lungs also won't suffer. So, we buy time like this. So, wait for the baby to grow to 31-32 weeks and then deliver the baby, and after that the treatment will be done by the pediatric surgeon. So, the in utero treatment here is only to buy time. Buy time, not to make the damage more, so that even after the surgery is done the babies may not do well. So, it is a very complex decision to make to do an in utero procedure. The other conditions which we do an in utero procedure would be when the baby has fluid collection behind the lungs. Due to some reason, the lungs may not develop. Even though the lungs do not function during the intrauterine life, they have to be ready when the baby is born. For that, the lungs need to expand. So, what we do is we put a shunt in the pleural space, let the fluid out, and so the lungs can expand. The other condition would be the fetal diaphragmatic hernia. What a diaphragmatic hernia means is when the baby's bowel gets into the fetal chest and it does not let the lungs grow. So, in that condition also, we put in a balloon into the fetal trachea, keep the lungs expanded. So, the lungs do not get hypoplastic or become small during the intrauterine period. So, many of the babies with congenital diaphragmatic hernia die not because of the hernia, because of the lungs are not developed at birth. So, to keep the lungs growing, we do a procedure, but the definitive operation of the diaphragmatic hernia will be done after birth. So, these mostly when I explain this procedure, you must have understood that most of the definitive procedures can be done only after birth, but for those procedures to be successful when they are done after birth, we need to do these intrauterine procedures to prevent progressive damage to the baby. The other defect would be a cardiac defect. There are some procedures, balloon valvuloplasty for the baby is being done to expand the valve to make sure the chambers do not become small, but still they are done in very few centers all over the world, and it's not done on a regular basis.
Thank you very much, Dr. Radhika. So, going forward, one important question that many parents would ask would be, now that we've come for the anomaly scan is normal. Will all the anomalies be picked up? Are any further scans needed?
No, not all the anomalies can be picked up at 20 weeks. As a baby grows and more and more anomalies we can pick up. Even before birth also we can pick up anomalies. After birth also some anomalies can be picked up. And even after baby grows, over a period of time also some anomalies come into play. So it's not the one and only answer to rule out anomalies, but about 70 to 80% of anomalies can be picked up in the 20-week scan. Still we have to watch out for late onset anomalies, anomalies which present at birth or even later. So the good news is 80% of scans can be picked up by 20-week scan. At the same time, we have to understand that we cannot assure complete normalcy of the fetus at this point of time, and we have to keep monitoring the baby. Thank you.